Good morning, good afternoon, everyone. Welcome to this episode of this series of workshops on HIV prevention needs estimates. Today's workshop is going to focus on concentrated epidemics with a focus on Asia Pacific. This slide is just to highlight a few housekeeping for this workshop. Um, we will share the slides as a number of us will always request during our chats during the workshops if we share the content or the resources from the workshop. So we're going to share the slides from this workshop together with its recordings. Would like to encourage us to engage through the chat. And regarding the chat, I want us to separate the different chats here. We have a Q&A specific function on this meeting setup and a general chat function setup as well. Let's use the general chat setup to provide reflections, to comment, to share any additional resources related to what is being discussed. And let's use the Q&A chat to post specific questions related to the conversations. This will help us to be able to track all questions and ensure that every participant question is responded to. The objective for those who haven't joined, because we've been having these workshops for different regions, the objectives of this series of workshops is to explain some strategic directions for HIV prevention in a new context, aligning with the 2030 targets, as well as some rationale for prevention needs estimates. We would also like participants to familiarize with the new spectrum needs estimates tools, as you're going to see throughout this workshop. We're also going to share some basic information on a more detailed needs estimates tools, PREPIT, as well as CNET as relevant for this region. And most importantly, would like to find time during this workshop to discuss the implications for target setting and the use of these estimates, either for national HIV prevention planning, for the Global Fund GC8 proposals, as well as other purposes as needed by countries. As I highlighted earlier on, we have been running these workshops for different regions and two more workshops still to come. We have done workshop for generalized epidemics focusing on ESA and WCA. We have done also another one on concentrated epidemics focusing on selected countries from the same regions as well as MENA. Today, there's a focus on Asia Pacific. 2nd of March, we will focus on Latin America and the Caribbean, and then Eastern Europe and Central Asia, as well as West and Central Europe and North America or other high-income countries on the 9th of March, which will be the last workshop. All resources for all workshops will be available on the Global HIV Prevention Coalition Resource Hub. So if you're interested in seeing what has been done in other workshops, we'll provide you the link during this workshop for you to check resources from other workshops as well. The agenda is as shown on this slide here. I'm going to be chairing this workshop or helping to facilitate this workshop. I'm not sure if our director, Dr. Forde, if he's around to provide welcoming remarks here. If not, we'll go straight to Mary Mahay, the Director for Data for Impact, to provide some introduction. Would like to link or for you to be able to see the link between this prevention needs workshop and the regular estimates process that you're all familiar with. And then I'll give it to my colleague Clemens to provide some opening introductions, just providing some highlights on the estimates process and prevention needs, and also how it links to the 2030 Prevention Access Framework. And then we'll give to Avene, colleagues in Avene, to provide a more overall introduction of the functionality and assumptions of the suite of these tools in Spectrum, focusing on the prevention needs estimates. Then we have a short Q&A session for those different presentations there. After that, we'll go to specific tools or specific needs estimates. First, PrEP, we'll look at estimating the need for PrEP, and then we'll go to estimating the need for condoms. And then we'll also look at the third part of this suite of tools, which focus on key populations size estimates. And for these specific tools, PrEP, It will be Nicole Bello from Avene. And also the condom needs estimates. We're going to have my colleague Clemens and then also John Stover from Avene to share on those, and then Eileen on the key population size estimates, which is part of that suite of tools as well. Would like to also to give enough time to have a discussion and how we can link this to the Global Fund GC8, and also to hear what could be the country needs in terms of support to apply these tools as you prepare your proposals for Global Fund applications. That's our agenda for today. And then without wasting more time, I would like to give to Mary Mahe, if Dr. Forde is not in. Over to you, Mary.
Thanks, and I'm just sharing my slides. So good afternoon. I think most of you are in afternoon. Really glad to be with you today. And my point of this presentation is one, to welcome you and to appreciate co-hosting this with Fode and his team working on prevention. And so I represent the data and evidence team at UNAIDS and wanted to walk you through some of the linkage between what you'll talk about today and how it's linked to the whole global AIDS monitoring process. And watching the welcoming, the introductions on the chat just now, I recognize that there's folks on this call that might not really be involved in the global AIDS monitoring, but what this is every year UNAIDS asks countries to submit data on their HIV epidemic and their HIV response, so that we can compile it and look at the global level, what's going on, and at regional level as well. And so my presentation is just linking those two processes, and it'll be very short. But every 5 years, UNAIDS pulls together partners to say, what do we want to achieve in the epidemic, and how do we make sure that we'll end AIDS by 2030, our ultimate goal, but what are the steps we need to do to get there? And the first thing we do is we set global targets, and these are targets that get adopted by countries, but they allow a country or a district or a region to say, what do I want to achieve? And so we did this in 2024 and 2025 and came up with a list of 16 targets, and they're on the right side of the slide here. You'll see the second one there is on prevention, and I'll come back to that in a minute, but just a little bit more on these targets. These targets are then followed up by a strategy that says these are the interventions that need to take place in order to achieve these targets. Those interventions are then taken to a political declaration where all countries come and sit in and talk about those that political declaration and agree to these commitments, and the commitments are those targets. So those targets are then adopted, and they will be so in June of 2026. We've gone ahead and adopted them now into the global AIDS monitoring, and so what we'll be asking countries to report on in May of this year is how we're doing against those targets that are on the right side of this screen. Prevention within these targets is really critical. You can see it's the second one there, and there's what we call top-line targets. There's 16 top-line targets that are reflected on the right side. And then underneath this is a second tier of targets for when we're not achieving or when we can't measure some of those top-tier targets. So you can see for prevention, it's saying that 90% of people in need of prevention, whatever that prevention need might be, are receiving access or are using those prevention options. So PrEP, PEP, condoms, needle syringe programs, opioid agonistic maintenance therapy, those sorts of interventions is what we'll talk about today. But how do you measure the need for that? And so again, we can't necessarily collect that target that's summarized there. And so we look at the intervention-specific targets in this case, and that's what we'll talk about today. So prevention is absolutely essential within our global targets, and we recognize that in order to get towards ending AIDS, we need to stop the new infections. We're doing this within the estimates process, and so many of you will be involved in the estimates trainings where we go through Spectrum, we have you update your data, we have you update your Spectrum file. Within that now is a new Spectrum needs Spectrum denominators section where you can find out how many people roughly do I need to reach with condoms? How many people do I need to reach with PrEP? So you can see your progress towards those. So that's all part of the estimates process that will go on now. my last point here is just to say that will then be recorded in the global AIDS monitoring process. That framework then goes out and measures progress towards these 16 targets. And your focal points, your global AIDS monitoring focal points will be aware of that. My last slide here is just a image of what that looks like on the online tool that it has to get entered into. And so what we're asking for, this is just PrEP as an example, we're looking for the numbers on oral or the vaginal ring or CAB-LA or LEN by the age groups and sex that are receiving that intervention. And then we ask you for the denominators. And this is the part that we're talking about today. How do we estimate that denominator? How do we calculate that? And then we'd ask you to put that entry in here. Actually, it's automatically populated with your spectrum file. So that's the connection then to the global AIDS monitoring and to the whole global AIDS strategy. So I'll stop here. If you have any questions, though, don't hesitate to ask any of us in the data and evidence team, specifically on the GAM or the estimates process. But over to you, Lysias, then. Thanks.
Thanks so much, Mary, for that introduction and providing the link between these processes for colleagues to be clear on how these are related. I would like to give to my colleague, Clemens, over to you for the next presentation.
Thank you so much, Lysias. I am sharing my slides, and I will be speaking briefly about the global HIV prevention access framework. I hope it's coming out okay in the display.
Yes.
Thank you. So the Global Prevention Access Framework basically elaborates on the global AIDS strategy target that Mary just showed, which is one of the 6 areas here, the primary prevention target. And it actually describes this at the moment of the world being at the tipping point, where we see that if we reduce our focus on primary prevention, and that's the red line here, we will definitely not achieve our targets globally and actually see a reversal of some of the gains that we've made, and we would prolong the epidemic way beyond 2030 rather than achieving the targets of a 90% incidence reduction that Mary has just explained. The framework sets out a bold vision that by 2030, every person at risk of HIV or in need of HIV prevention will have access to a prevention option that suits their need. But of course, this framework also comes at the moment of a funding crisis, which in Asia Pacific might not affect many of the upper middle income countries, but it will still affect a number of countries in the lower middle income segment and countries that have been dependent on prevention for key population programs, for specific components like PrEP or harm reduction. And the framework therefore highlights the need to optimally use available resources. So what are the main strategic shifts at this moment? There is a focus from an intervention-centered or often project-specific, population-specific, or intervention meaning tool-specific PrEP or condom-specific programs to a person-centered, more holistic prevention approach. We, of course, have long-term options coming into the mix. There's a move from aspirational long-term targets, which we still need. We still need a 2030 target in terms of incidence reduction. But unlike treatment, we have not had annual numeric targets, often as precisely defined for prevention. And this is what the new framework sets out. And this closely relates, of course, to this needs estimation workshop. It's, as mentioned, a more national program approach with a sustainable sort of country-owned cost structure rather than donor-driven cost structure, expansion of self-care models, and shared responsibility based on ability to pay. And that's, of course, between countries and donors, but also in terms of what people refer to as total market approaches, is see, which populations need prevention most and need public support most. The framework then outlines different dimensions of action, and it has a dimension of knowledge and understanding one's prevention need, which you could also refer to as behavioral dimensions. It has a systems dimension and what are actually the access platforms for prevention. It has number 3 here, the bottom right, of course, the different prevention options relevant to the epidemic context, and it has specific barriers and enablers in terms of the structural dimensions. And what the framework recognizes is, and this is perhaps not new, but is that we can have a systematic approach and in each of those dimensions select the most important issues and platforms and interventions systematically in an overall design of the response. The targets that Mary already mentioned culminate in this 90% use here in the middle of prevention options among people in need of prevention. But it really starts at the denominators. And the denominators here are people, so we need to understand the population sizes, of course, in Asia Pacific with a strong focus on key populations, and then prevention denominators, which for some populations, for sex workers, for example, are pretty equivalent to the population size. For other populations, like men who have sex with men, there's differentiation needed, or those who have maybe one regular partner and others who have non-regular partners, who would then be part of the prevention denominator. So with that denominator, then there's a 95% access or coverage target in terms of reach of prevention options, reach of prevention, outreach or person-centered programs with those behavioral dimensions as well. And then if 90% of the people in need of prevention are reached, you get to that 90% use of prevention options. So in a way, it's a little bit like the cascade logic from the first to the second 90 in HIV treatment, and then leading to a 90% incidence reduction, of course, in combination with the treatment programs and the enablers, of course, the 90% viral suppression being an important factor here. And what is also new here is, and this leads again to the scope of this workshop, is the strong emphasis on quantitative targets. And here you have a summary from with a global perspective. So these are the global targets as we have framed them: 40 million people accessing treatment, 20 million people using PrEP options, 20 billion condoms, actually largest share in Asia Pacific because of the largest population size, and 20% of domestic financing for HIV going actually to HIV prevention. And then you have also people-centered targets, because for the demand generation, if we do prevention in an integrated way, the people are the starting point, and we need to reach all the key and priority populations with HIV prevention. And then you have the higher level impact goals here on the right side. But what is, of course, most relevant for countries from this is that this kind of high-level advocacy framing for prevention and for reaching incidence reduction targets through, enhancing prevention access and coverage targets, is that this can be translated into country targets and even district targets. So here you see how this could look like for a country with a treatment target, a numeric one, which most countries already have, PrEP targets based on really granular analysis, as we'll see later in this workshop, condom targets, domestic financing targets, and prevention access targets. In Asia Pacific, probably mostly for key populations, but also some other priority populations, could be partner of key populations, also sometimes in discordant relations. So there will be a target there as well, likely in some of the countries. And then, of course, in more detail, the country target table could look like this, with annual targets for all of those indicators that we have shown. And this can then directly be linked to a systematic approach, if you remember the 4 quadrants, to the systems, to the trusted access platforms for prevention. And here you have a menu in this flower chart, and then perhaps for planning, even more interesting, a breakdown of the different access platforms by populations and by interventions, where countries could then look like systematically which platforms are most relevant for which types of prevention options and which populations. All of this is actually integrated into a prioritization framework with the 5 Ps of prioritization: prevention for the right people, the right places, the right packages, the best platforms, and at the right prices. And importantly, linking those 5 factors together and weighing them to achieve an optimal mix of prevention options, which again can only be achieved if we have a good needs estimates of HIV prevention. Now, how do those different exercises that we have here, or the different tools that we have, interrelate? The prevention needs estimation in Spectrum that you see on top, which will be the focus of today's workshop, really provide an annual synthesis of prevention need that is routinized. And that's the new thing here, that rather than, every few years maybe engaging in a PrEP or condom or population size estimation exercise, we routinely review the prevention needs estimates as part of our Spectrum estimates. And then, of course, there's still many more granular tools available. Of course, we have the allocative efficiency models like GOALS or AEM that has been used widely, or Optima, but AEM has been used widely in the Asia-Pacific region, of course. Then we have specific tools that will also look briefly, that go into more detail. Then, if you really want to go granular on PrEP, you can still use a PrEP tool, or for condoms, if you want to go in detail into, maybe total market analysis, resource planning, the CNET tool is available as well. And all of this will ultimately culminate in what you see here on this slide, where we see the targets basically from the needs estimation to the right, that would then ideally lead into some kind of program and market segmentation analysis for prevention options, what would be free, subsidized, and perhaps also sold access through the private market, what could be for the people-centered programs, facility, outreach, and virtual reach, and then the funding sources for all of these could also be decided between government and funding partners. Maybe one last word on prioritization. The general notion, of course, is that with higher HIV incidence, we would intensify HIV prevention, and that is the underlying logic, for example, also for the PrEP targets and the global algorithm of the PrEP targets, that it would increase with, of course, some other conditions associated as well for populations with higher incidence. But those should not be exclusion criteria, and people who actively seek access to interventions, for example, like PrEP, should not be denied access because of such criteria. So overall, a new era of HIV prevention, a new set of targets, a new approach to needs estimates that will enable more granular systematic analysis, annual tracking of progress, prioritization and alignment. So with this, we think we have a strong foundation to make 2026 really a year of a new prevention access push. Thanks so much.
Thanks, Clemens, for that overview and for linking this to the access framework. I'll hand over to John Stover from Avenir Health to provide a detailed overview of these tools, their functionality and assumptions made in those tools. After that, we have a question and answer session based on these presentations and so far. So over to you, John.
Actually, Lucius, Carl Pretorius is going to do the presentation.
Thanks, John. Yeah, over to you, Carol.
Thank you. Let me just share my screen here. All right. Can you see my presentation?
Yeah, perfect. It's good.
Great.
Thanks.
Well, good morning and good afternoon and good day to everyone. I think we're probably spanning about 12 hours of the day in time zones here. So thank you for the opportunity to talk a bit about this new tool in Spectrum. I'm not going to say too much about the epidemic itself in Asia Pacific and its characteristics, just a few remarks that it still has the second largest regional HIV epidemic, and there's still significant gaps in its prevention program and provision of prevention services. And we have available several tools that can support numeric prevention targets. So this presentation is about this a new Spectrum prevention tool. As mentioned, there are other tools also available, and we will get into them shortly. And they are used for more detailed prevention planning than we are going to do with this tool. But this tool is a very good streamlining of these various tools and can provide a very good starting point for planning and for more detailed planning. So the purpose of this tool is to assist countries with service delivery and commodity needs estimation around the achievement of the target for key prevention programs, such as condom programs, PrEP, key populations, and VMMC programs, which is not, as I'll get into shortly, VMMC we're not discussing in much detail for this region, but it is an important component of this tool for other regions. So there's, first of all, there's an Excel implementation of these tools that you can see in the chat. Those Excel versions were just pasted in there and shared previously too. But this is a tool that consolidates all of that into Spectrum. It is linked to your Spectrum AIM file, and it actually requires, when you are using it in Spectrum, it does require you having an AIM file. In the interim, the Excel tools can provide you with good insight how the tool works until you have an AIM file. But that will be the next step, is the finalization of an AIM file that you can then tie to these prevention needs. So these are the components of the tool. I'm just going to mention them in the order that they appear in the tool. So there is one for estimating condom needs. This component of the tool in Spectrum just replicates the calculations in the condom needs estimation tool. We'll get into that in another session. There is a VMMC component replicating the calculations of the DMPPT tool. It's not perhaps as relevant here in this region. There are no major public VMMC programs, so we're not going to get into details about this tool here. Key populations are, of course, very important, with many concentrated epidemics in the region. We'll get into that aspect of the tool. And finally, the PrEP tool that estimates PrEP need by target populations. This tool and component of the tool replicates the calculations from PrEP-IT. Just a few remarks about all these components. They are populated with default data. So in the Excel workbooks, you will see that the default data is stated there. So these are available for many countries. We use country data where available and regional averages for certain countries where we don't have country-specific data. All of these inputs can be edited. They're all used in the calculation patterns that we will discuss. None of these components do costing specifically in Spectrum, although they provide the denominators that are the starting point for more detailed costing and planning. The tools all have this appearance. There is first a listing in the left-hand side of the populations in the tool. So here we're first looking at the condom needs component of the tool. In the Excel versions of this tool, you can select your country and start to get a feel of how the tool works. There's a listing of the populations, in this case, following the populations that are used in CNET as well. And there'll be more discussion about those populations and the choices made there. But automatically, it would draw in our estimates of these populations. We will get into the sources of baseline coverage, but it also draws in estimates of those. There is then a target setting that is a target coverage that has to be set for all of these populations separately for the different components. And there's some specific settings for the different components. In the case of the condom use tool, we have to specify the number of sex acts for individuals in these population groups. I'm going to try and get my pointer here. Laser. So we have to specify the number of sex acts annual per in these populations, and also a wastage for which we use a default global average of 20% at the moment. So with these inputs, from the population sizes to the coverage to some other, and then some other inputs specific to the component, there's a calculation of the condoms required in each year leading up to the target year of 2030. So the user can edit all of these in blue or red, but not in green. You'll see in Spectrum, which we'll get into later, those things that are calculated are grayed out from editing. So you cannot edit them in Spectrum, although be careful in Excel not to disturb the calculations that underpin these estimates listed here. So as I mentioned, the population sizes are read from database. User input is where you provide your country-specific context here, and there's also a discussion around how these targets are conceived and set. At the moment, they are defaulted to the global targets. So that is the basic layout of these components in the new prevention tool. I'm going to proceed quickly to the key populations tool. Here again, we have the populations that are reached by this key population services. Again, an estimate of the population sizes are read from database. In this case, the estimates are based on UNAIDS consensus estimates or the Atlas estimates for key populations. Again, we have global targets as our default target coverage for 2030 for all of these key populations from the UNAIDS targets work. And then again, a calculation in the green area here that you will see in your Excel versions, where the calculation combines these inputs and that you cannot edit. So that gives you an idea of key populations reached by these specific services. PrEP follows a similar pattern. We first look at the definition of the populations in need of PrEP. That again is read in from a database. So the targets set for PrEP is a bit more complex. We will get into that in a subsequent session, but it's tied to a sliding scale where we use incidence as an input to the computation of the target. But otherwise, the same pattern. We have target populations, their sizes, the specification of a target level for 2030 that we start off with at the UNAIDS target levels, and then a calculation of the number receiving PrEP with the PrEP need. This component has further details also around the method mix for PrEP. So the user can specify the proportion receiving oral PrEP, ring, CAB, or LEN, and that is assumed to be fixed over the period of the projection, but that is taken into account. So the total PrEP need is split up automatically into these components that you can then further use in your planning. This slide, This slide is a summary of sources of estimates for population sizes. So on the rightmost column, we have the sources, and then we have these components of the tool showing how the sources pertain to certain populations. So the consensus estimates from UNAIDS are used in key populations. For example, the Atlas estimates used for key population sizes. The World Population Prospect data is used for several components to estimate, especially elements or sizes related to age categories or age brackets. From DHS, we get several estimates needed in the condom tool around self-reported condom use and family planning needs estimates. Naomi is widely used for the VMC tool, not relevant in this region, but it is an important tool for those countries looking at detailed VMC planning. From GAM, we get estimates for pregnant and breastfeeding people, and so on. So this is detailed. All the sources are detailed here and is available once you start researching the tool. Estimates of current coverage, also from GAM in several instances. We get estimates from THEA, again, UNAIDS consensus estimates or Atlas estimates for key population services. DHS is our source for family planning condom use estimates. So all of these default estimates are already pulled into a database that is made available with the tool. And that is why almost all of the countries can just load their own file or use the Excel file selecting your country, and you will get access to all of these default estimates. Finally, the targets. They are currently based on the 2030 global targets that Clemens has also briefly described. The PrEP one is the one that will take a bit of clarification. It's based on a sliding scale between a minimum and a maximum bound, or a minimum and a maximum incidence where the maximum coverage of 80% is reached. If you are familiar with Spectrum and you have an AIM file, there is a section, and you open your AIM file, there's a section called Tools, and within that you can just press on this option called Prevention Needs, that will open this interface, which looks just like I described. We have our populations listed. They can be edited. Our target coverage can be edited, starting off with the global targets. We have some component-specific entries, like for condoms, we have sex acts and wastage, and for PrEP, we have to pay special attention to the sliding scale targets and also the method mix. And then you'll see, as I mentioned, the graying out of calculated entries, so those can't be edited. We'll share the slides with you shortly, and you have received also links to the software and also links to the Excel files themselves. There's also an online version of Spectrum that we may discuss in a bit more detail later, where this tool is also available. Okay, thank you very much. That brings me to the summary of this tool, and in the course of the next couple of hours, we'll go into details into the various components of the tool. Thank you.
Thanks. Thank you so much, Carol, for that detailed overview of these tools in Spectrum. We'll open for questions. Let's spend the next few minutes to ask any questions you have and responding to those questions. You can raise your hand and we'll ask you to unmute, and then we can speak if you prefer speaking. Also, feel free to post on the Q&A function. We are monitoring that function to respond to those questions. Any questions? I see one. John has already responded to it already. For those who are monitoring the Q&A function, somebody was asking, can country export PrEP-IT2 into Spectrum if they've already have the JSON files. And the response to that is you cannot export the Prepit inputs as a JSON file, but you can copy and paste the inputs from Prepit into Spectrum Prevention Needs tool. Any clarifying questions? Feel free to ask, because the next sessions will go into detail into these specific tools with exercises to follow. So if you've got any clarifying questions, feel free to ask now. I see somebody posted in the general chat function saying how the size of serodiscordant couple is being estimated. John has already responded to that as well, saying it is estimated from a regression equation based on the HIV prevalence among all adults 15 to 49. You can raise your hand if you have any clarifying question. If typing takes time for you, you can raise your hand and then we can unmute you. Otherwise, we can go to the next part of this workshop, which is looking at the specific tools. And for that, we'll start with estimating the need for PrEP. And Nicole from Avenir Health will share on Prepit. It's good to clarify here also, as Clemens highlighted earlier on, we have these dedicated tools, right? The standalone tools like Prepit, they provide more outputs than outputs that you get from the functionality incorporated into Spectrum. So this is not to replace those tools, but to give you a very quick way of estimating need for those prevention options. I'll hand over to you, Nicole, to give us a walkthrough of Prepit. Thank you.
Great. Hello, everyone. Good afternoon. Are we seeing my slides? Can you see them, Lysias?
Yes, perfect. Yeah,
Great.
really good. Thank you.
Okay, super. Hi, everyone. My name is Nicole Bellows. I'm also at Avenir Health, and I'm going to give you just a brief overview of the Prepit tool. As Carl mentioned, it goes into a lot more detail around PrEP planning, but there are some overlaps around setting targets and making estimates. So Prepit stands for the PrEP Implementation, Planning, Monitoring, and Evaluation Tool. It was developed in 2019 through a number of different PEPFAR and USAID projects, as well as further development under the Mosaic Consortium. It's a decision-making and analysis tool that has interrelated modules. Most people use it for target setting, but it's also used for cost forecasting, estimating your impact, and commodity forecasting. And I'll talk a bit about all of those. This is the landing page at prepitweb.org. To get started, you press the start button on the left. There's also an aggregate feature if you've done several different estimates on different subnational regions and you want to aggregate them within your country. We won't talk about that today. But also just to sort of familiarize yourself, this tool is available in both English and French, as you can see up at the top. And that's how you get started. Several countries have used Prepit over the last 5 years, mostly around target setting. We also see it for a lot of like COP planning, global fund applications, and some people have used it for commodities forecasting. Most recently, countries have been using it to help with their lenacapavir rollout. When estimating population size estimates, we look at these like 4 dimensions. Obviously, the total priority population size. Then in some cases where PrEP is only prioritized for certain geographic areas, or at least targets are being focused on geographic areas, looking at the proportion of the population in those areas. Of course, we want to capture those who are HIV negative, so we take prevalence into account. And then we look at the percent indicated for PrEP, or the percent of the population that are in need of PrEP based on their likelihood of exposure to HIV. And with those, we can get to our potential PrEP clients. In terms of methods, there are 4 default methods in the tool: oral PrEP, ring, CAB, and lenacapavir. And they have some assumptions around the unit costs and the effectiveness, but these are all editable in the tool if you have different costs. And you can customize your method mix in terms of what you want to include during this process. And if you can even add new methods, but you have to add in some assumptions around the costs and effectiveness and your implementation timeline. One key feature of PrEP-It is that it tracks clients over time, considering how long people stay on PrEP. So these are what we call the continuation curves, where month 0 is when they initiate PrEP. And there are different estimates of how long people stay on PrEP over time. There are defaults in the tool based on prior implementation studies, but if you know how long people stay on PrEP, you can also edit these and customize it to your particular population. Our costing module has 3 different types of costs that we look at. There are those monthly costs based on the PrEP product, and that could include also some adherence support. And then we look at the costs per visit, and we separate out initiation visits when people start, as well as the refill visits, and looking at the different dimensions on visit costs. And then your lump sum costs that go across your entire program that could be for demand creation, management, et cetera. So the tool has default cost estimates for each country that are based on an analysis of prior costing data and then adjusted to sort of the wage data within a specific country. So you can use those defaults, especially if you don't know what your cost per visit is. But if you have that data, of course, you can enter that as well. And then when combined with the targets module, then when you're looking at the total costs of achieving those targets, and you can also do cost effectiveness analysis, looking at the cost per infection averted by PrEP method and population. And this all takes into account how long people stay on PrEP, how many of them reinitiate, what their visit schedules are like, and their scale-up trends. So there's a lot of details in the back end that go into these cost estimates that the tool does for you. When looking at the impact, PrEP-It calculates the number of HIV infections averted based on these impact factors, which are the modeled number of HIV infections averted per person year on PrEP. These are estimated on the back end using the Spectrum Goals model, and they take into account method effectiveness and the projected incidence in each population. And then, as I said before, these can then be linked with your costs to look at the cost effectiveness of achieving your targets. And that's useful for some. When setting targets, you have 3 options. The first is to look at coverage. And what we mean by coverage are the percent of the population who will be actively taking PrEP at the end of the target setting period. So this is not the same as the percent who have ever started PrEP, although that's calculated separately, but really give you a sense of like at a given point in time, once you've achieved your targets, what percent of that priority population do you want to be taking PrEP? Now, ideally, that's, a high percentage, but we also have constraints, and we also have people dropping off and not taking PrEP continually. So that can't be 100% of people taking it actively. But you can add in your constraints as well, which might be a dollar amount or a monetary amount or it could be the amount of product that you have available. So you can add in constraints, and then they will calculate what that coverage will be. Another feature that's useful is maybe you've already set targets using another mechanism, but you want to know the impact and the costs. You can enter in your targets specifically, and then you can look at the cost and impact implications of those targets. Or you can also use that to help understand your commodities forecasting needs. And again, you can specify a method mix when you're setting these targets. There are a lot of different tool outputs. It'll give you those indicators, PrEP new, PrEP CT. They'll tell you how many people received PrEP and how many are on PrEP in the final month of the target setting period. And then for each population and method, it'll give you the total number of initiations, how many people reinitiate, the infections averted, the cost per infection averted, that actual coverage level achieved, and the percent of those potential users who are expected to initiate over the target setting period. There's an optional feature to disaggregate your targets then down to the subnational areas. And then the commodities forecasting piece, as I mentioned, shows the monthly estimates of expected visits, the amount of PrEP product needed, and monthly commodity costs. So that's where tracking each client over time is useful for those planning needs. So, for the sake of time, we've really just touched on the overall aspects of the tool, but there's a lot of details and instructional presentations for each component of the tool. Those can be found on the PrEP Watch page at the address here. If you're using the tool and you have questions or need help, we have a help email here. And there's also an online community of practice that you can engage with other users of the tool. So I'll stop there. Thank you.
Thanks, Nico, for that presentation. We had a country example from the previous workshop. We couldn't get a country example from this region here. But are there any questions here before we can do the exercise? I think it's important for us to be able to go to the tools themselves, be familiar with how the tools work, be able to read the outputs, be able to know where you can make edits in terms of editable data, input data, know where you are not able to edit, be able to interpret the outputs for prevention planning. Any clarifying questions that anyone has so far? If there are no clarifying questions, I will have to give back to our Avenir colleagues to walk us through the exercise. We want this to be as practical as possible. So over to you. It will be you, Carol, or John?
Sure. I mean,
Okay.
I'm happy to show the actual tool and
Yes, yeah. And for the colleagues, we sent some notes on or some guidance around how to set up either installing Spectrum. If you don't have it installed, you can install, or using the web-based Spectrum also. And then we have shared the Excel versions of the tools. Maybe if it's too late for you to install or you're not sure how to do that, during this exercise, you can make use of the Excel tools to follow through the exercise. But then it's important to be able to then familiarize yourself with how this is in Spectrum. We'll go through this exercise. Carol is going to show us the tools, how they work, how do we read, where we make edits in terms of editable input data. then would like to be following up, I'll encourage you to follow up as you'll be showing us that you do it on your computer to follow through those steps so that you can get some kind of an output that you can then be able to interpret. At the end, we're going to have a quick Menti exercise based on this exercise here. It's important, I think, for you, especially for those who are going to be involved in preparing prevention sections of the Global Fund applications, to be able to quantify your prevention needs that can then be translated into costs that can be requested as part of your proposals. So yes, over to you, Carol. Yeah.
Thanks, Lysias. I'll just share my screen here. All right. So I will first show you briefly in Spectrum itself. So I have a file here that's just a sample file. So once you've created your AIM file and have access to it, you'll be able to load it into Spectrum and look at this as the specific tool. It resides in this section called More Tools, and it's right here, Prevention Needs. It looks identical to the presentations that I shared. Would it be more helpful to work directly in the Excel workbook, for assuming that not everyone has access to a Spectrum, but it's identical. The only difference there is you'll select your country, whereas I already have a country selected here. How do you think is best, Lysias?
It would be easy, I think, with Excel.
Okay.
Then we can then have maybe a few minutes after the Excel show through to just for those who are using Spectrum already, you can just show them quickly. I think for those ones it will be easy. It won't take them long for them to figure it out. We can show them with Spectrum. I will also share a sample Spectrum file that those can follow. But I think Excel will be easier for everyone for now.
Yeah. Okay, so that's the route through Spectrum. And then we've provided 3 separate Excel workbooks. One is for Prep Need, and there's another one for Condom, and also VMC that we won't look at. So this is what, if you open the, I'll have to share my whole screen here for you to see that, I guess. Can you just tell me when that's loaded?
We can see your Excel now, yeah.
Okay, great. I hope it's clear enough. I can try to enlarge it a little bit. So these are the, on the left-hand side is the enumeration of the specific target population groups that we work with. As I mentioned, we have access to a default database. You can see in this sheet where the estimates come from that are pulled into here, and these are automatically read in. And you can refine all of this, and you can also edit these values directly in Excel as well as in Spectrum. The default coverage levels from the GAM reports are listed in here. You can do a calculation also if you have more recent information about a specific population group of one of these population groups of a default coverage. The target coverage
just a quick, sorry, Carol, just a quick pause. So I just want to encourage colleagues, if you are left behind following through what Carol is describing, just indicate in the chat box, say, hey, I'm behind, can you repeat that step? And then we'll be checking the chat box. We don't want you to fall behind. At the end, we would like you to be able to be familiar with how this works and how to do it on your own. So feel free to just paste in the chat, say, hey, I'm behind, or I missed that step. Can you repeat it? And then we'll be following through. Thanks, Carol. Over.
Yeah, thank you. So in this region, PrEP is, we have essentially quite low levels of PrEP, quite far beyond or below the target suggested by, the UNAIDS global targets work. So baseline coverages are very low still, or relatively low. As I mentioned, the coverage levels are a bit more complex, so they are based on a sliding scale. We didn't have a presentation on that, but there is a summary available on how that sliding scale works. But essentially, it looks at incidence. So the target coverage is tied to incidence with a 2% incidence achieving a maximum coverage level. Now, for key populations, the starting point is 0. So it's a linear scale between 0 and 2% that determines what is the coverage level for a particular country for certain groups. For these groups, the adolescent young people, so there is a minimum value of 0.2 and then a sliding scale to 2%. We can get into that. Ultimately, that has to be thought out and discussed in your context, a target set, and then we just simply connect these target levels to the population's estimates of the populations in need, and there'll be an estimate then for example, by 2030, what would be the number receiving PrEP if that stated target percentage of those in need receive PrEP. Here at the bottom is a total. You can use that total to compare to estimates to your best information on PrEP PrEP volumes from your country, and also you can use this estimate together with your total estimate for incidence. In the slide that we will share later, there is a mention of a sort of an overall minimum coverage level for PrEP. So there is a lot of uncertainty, or there is significant uncertainty in this population sizes and other elements that go into this calculation. And ultimately, to reach the impact targets by 2030, there is a kind of a minimum level for PrEP coverage that is around 5 people receiving PrEP per infection of per new infection in your country. So once you have an estimates file that does give a robust incidence estimate, you can and once you have robust estimates in this group, you can do a calculation like that to try and estimate what is your overall number of PrEP per incidence averted, and ensure that that is not too low. But these are a few tools that you can use to set these targets for PrEP numbers receiving PrEP. For the PrEP tool, there is a bit more detail that you have to work through, which is the method mix. So I misspoke in my presentation. You can actually set a time dependency in the PrEP mix. So many countries will start with 100% oral PrEP and then transition perhaps into 6-month injectable LEN over time, or a proportion of them would go to LEN and another proportion to ring, whatever the case may be, relevant to your country context and your procurement plans and your population groups that you prioritize. There is a specific method mix that will make sense, and you have to work through that as well. And then it will split the person years of PrEP required up into these method mixes per year, and you can study those then also as part of procurement plans. There's some parameters here related to the method mix, default mix values, and so on. All of that which you will receive when you select your country, but which you can then override when you make a more context-specific calculation of what is needed in your country. So that's the PrEP layout. Is there any questions at this point? I just want to see. So here's the country. Here's where you select your country. That's in line number 22. So I've selected Indonesia here. You can select your country, in which case the process will begin where you evaluate the default populations, can evaluate your baseline coverages. As I mentioned, this is very low and significantly below the target level. So overall, as a region, there must be significant scale up by 2030 to come close to the targets that are set for PrEP volumes by 2030. Method mix is also a key consideration with many countries transitioning to LEN. And as Nicole mentioned, a lot of the uses of PrEP at the moment is to study this transmission to 6 month injectable or LEN. So I think, yeah, let's give everyone a chance to select their country, and we can start the process of reviewing these default inputs. I think for now, you can maybe accept the default just to see the calculation pattern. I mean, you can play around with the target levels and see how that influences the total volume of PrEP in 2030 that is projected for this country. You can pay special attention to the population groups that are relevant. So most of the epidemic is concentrated in key populations, and that's why by default we're not prioritizing PrEP to adolescent young people, but that is also something you can review. That's why the target coverages are 0. So I'll give you a minute or two to play around with these inputs. You can then, for those of you with access to a name file, can study it directly in Spectrum as well. There in Spectrum, the parts that you can't edit will be grayed out from editing. Here, you can still affect calculated values. So be careful not to do that. So be careful not to disturb the formulas that connect the coverage with the population sizes.
Thanks, Carol.
Yes.
And I see an important, that question has been coming up in different workshops as well, like a classification of this default. Where do you get these default figures, especially for key populations, for example, or for the different populations?
Yeah, for the default figures, I mean, they come from a variety of databases, and we can get into more details, but that is back to this slide, where the defaults come from. So we have a number of publicly available data sources, from the World Population Prospects to Naomi estimates for countries where that's relevant. GAM reporting is a source of important information here, and also this tool will ultimately also help to make it more routine to submit some of the indicators to GAM. DHS used for several indicators. So, for example, the sources of the current coverage level, the 2026 coverage level. Again, there we use DHS, FIA where available. We have done extensive work with UNAIDS on Atlas and other estimates. Those are, so that's the sources of defaults. In the workbook, they are included, so that it allows you to select your country data, and this is where they are pulled, made available. But this workbook is more of a intermediary step to allow progress in this workshop. Ultimately, the tool will reside in Spectrum. Well, it does reside in Spectrum, but that is where we'll use it, and where default values will be communicated. But they come from our established databases that we use widely in Spectrum and other work, and it's summarized here just for PrEP in this tab.
So I see also a question here from Pradeep saying, I think Pradeep, you noticed that the key population size estimates are not reflective of what they should be for India. Yeah, it's a good question. I think that speaks to whether there are now new values for India that are yet to be reported in the next GAM cycle, or unless you refer to the ones reported in the last cycle are not the ones reflected here. maybe if that question could be clarified. There's also another question in the Q&A, but this is speaking to more on PrEP programming, speaking to scale up. This question, I'll give it to my colleague, Heather Murray, our PrEP expert, who also has worked in the region as well. Heather Murray, I'm not sure if you're online. There's a question there that is saying, as we all know, our oral PrEP coverage, this is Thailand, in the region is very low. Are there guidance to countries in the region to significantly scale up this intervention? Whilst we are working on this exercise, I'll be just asking different panelists to respond to some of these questions. Yeah. If you are able to just come in, Heather Murray, to respond to that question from Thailand, while his colleagues are working on this Excel exercise. Another good question again from Pradeep there, asking, in Spectrum, would this be auto-linked to key population size estimates for AIM, for the AIM model? And the answer there from John says, no, at the moment, these are not linked to the EPP size estimates. That is something Avene colleagues could look into in the future if countries feel that's useful.
Okay.
If you are lost in this exercise, just indicate in the chat or raise your hand. We can ask you to speak. We can unmute you to speak. We want you to be able to be familiar with these tools. Where do you get the input data? Is the data indicated now the default ones? Is it familiar data for your country? How do you read the outputs?
I see a question on the coverage levels for PrEP and how it's linked to incidence. Do you see my slide here that I'm showing to? Lysias, do you see my
Yes,
slide?
yeah.
Can I?
Yeah, I see your slide, yes.
Sure. So there is another short presentation with a little bit more context before the presentation that Nicole gave. But inside of that presentation, the key one is around the target setting for PrEP based on a sliding scale, which itself is based on incidence. So how it works is that the idea is that PrEP should be prioritized, to high incidence populations. And if you do subnational analysis to high incidence locations or geographies, for it to be cost effective. In the global targets, these are the levels that are used. We have a maximum target of 80% in these respective groups: young people, female sex workers, men. So that's the 80% over here. And then for the key populations like female sex workers, MSM, and people who inject drugs, we have a sliding scale. So if an incidence is, let's say, 0.5%, which is here, we locate it on the scale and we read off what the value is. So in the workbook and in the tool, the default values, they do these calculations for you. But you can also do them if you're going to adjust and modify this analysis. So at 2%, we have a maximum of 80% coverage, and then in between 0 and 2% incidence, we have varying levels of coverage. AGYW typically different, so there is a minimum level, not of 0, but of 0.2%. So PrEP is not given below that in the calculation of the default, but nothing stops you from allocating PrEP exactly how you want. And then maximum coverage is reached at 2% incidence level. So that is just an idea to tie it to incidence and emphasize the importance of prioritizing to high incidence populations and groups. The comment that I made about an overall target. So while there's a lot of uncertainty around the population sizes and other elements of this target setting, so for India and other countries, perhaps your population sizes aren't the best estimate you have, and even the best estimate you have will also have uncertainty. So there is another check that you can do, which is to study the overall PrEP volume that is estimated, let's say in 2030 or another year, and relate that to the number of new infections that you can obtain from your AIM estimate or from your official estimates process. And we don't want, well, it's not one threshold you can study is to see if there's fewer than 5 persons on PrEP per new infection, you can reconsider your coverage levels and perhaps see if a further increase in coverage is needed. Without sufficient amount of PrEP, there isn't gonna, it'll be really challenging to reach the overall impact targets. And as I mentioned in the beginning of my presentation, Asia Pacific, as the rest of the world, is significantly behind the overall PrEP targets at this stage. I hope that was helpful. Please ask if we can try and clarify it further.
Thanks, Carol. Just to highlight to colleagues online here that this slide here, a number of countries after the ESA and the WCA workshop, the generalized epidemic, it has been coming up because some countries are now going ahead to try and do the target exercise for PrEP, and they're trying to understand this sliding scale approach. So as Carol is highlighting, if it's not clear, indicate and we'll ask Carol to explain again. We'll ask colleagues to provide more clarification here so that you know how it works and how to do it. It's a question that came from a few colleagues after the workshops we've done so far. Yeah.
Do we want to go back to the workbook and perhaps look more carefully at the individual steps? I mean, the tool is new, and I see a comment in the chat that a more step-by-step approach can work.
Yeah, sure. I think let's do that, as colleagues will be following through that before we can.
Yeah, so I'm happy to talk around specific steps. The first is the selection of your country. So in cell A23 of the sheet PrEP needs tool, you can select your country. And I think most of the countries in this, we have about 35 countries, I think, in the Asia Pacific region, which you can select and study in this workbook. The analogous thing you would do in Spectrum is really just to load your national AIM file. Once you've loaded your national AIM file, you can access the tool. Let me just try and minimize this. You can access the tool here on the prevention needs. But either approach, whether you go for the workbook and through the prevention needs, is similar. Keep in mind that, you know, the workbook is really an intermediary step. The tool in Spectrum is where we will keep a copy of your inputs that you've changed, and it will be linked to your aim file. So going forward, that is the approach we want to take. For illustrative purposes, we can look at the workbook, but it's not the official way to collect this information. I think the first step for most users new to the tool would just be to first of all become familiar with the range of default values that we are using. So all of these tools, whether it's the PrEP tool, the condom tool, or the VMMC tool, need population size estimates. So in order for you to have a streamlined start, we extract these estimates from databases where we have done over many years a lot of work to provide these estimates of population sizes. They're not perfect. They come with uncertainty, and as while doing analysis, you can keep such uncertainties in mind and use it in your design of your targets. We have, after the population sizes, we really study the coverages. So there's a baseline coverage in 2030. That is an input you can edit. At the moment, that entry is linked to a lookup function, which looks up the value from the database. So once you've edited here, you can't get access anymore to the database value unless you reinstate the formula that was deleted. In Spectrum, once you work with the tool, you can restore the database default. So once you've edited and you've looked at a particular scenario of setting targets, you can restore the defaults if you want to try something else, or if you just want to start the analysis from the default target levels, keeping in mind that they are our best attempt at illustrating what the target should be in order to be compatible with reaching the global impact targets. So back to the workbook. Once we have the baseline target in 2025, you can turn your attention to setting a target for 2030. So this is across these areas of PrEP and key populations and condoms and VMMC, even though, as I mentioned, VMC not important here. This is a comprehensive discussion around, combination prevention and fulfilling the prevention targets that were explained at a high level by Clemens in the beginning. But we provide a starting point here where, as I mentioned, these target levels are, in the case of PrEP, they are tied to a sliding scale where above 2%, with 2% and above incidence in the particular population group gets the maximum coverage of 80%, and then some adjustments lower down for typically lower incidence that is observed than 2%, which is a very high incidence annually. In the case of Asia Pacific, we don't have the PrEP targets set for, let's say, adolescent girls, young women, or adolescent young people. For a range of estimates we need there, we don't produce those incidence estimates specifically for at default for PrEP for countries in Asia Pacific. But if you have a program that wants to look at targeting PrEP to a specific proportion of these populations, you can fill in the target levels and the baseline coverage levels and the target levels. Once you provided those, you have a calculation of PrEP need that extends from the first year, 2025 to 2030. It does a linear interpolation of the target, of the coverage level and of the population sizes, and it does this calculation. In the Excel workbook, this calculation, you'll see the calculation formulas. They are listed here. There's the interpolation that's done over the 5 years And if you delete that or edit that, you would have disturbed the formula. So pay attention to that. You can't easily reinstate that. Just don't save the workbook and open a new copy in the workbook in that case. And then finally, once you have the number receiving prep, you can start to look at how to split that up between different methods. So oral prep is still the dominant method in most countries. Let's say a typical assumption would be that we start with 100% oral prep and that we're going to transition into the other methods that have since been approved and are being brought into the program now, specifically LEN, that is used in many there's already several early adopting countries for LEN, and many more will very likely adopt this method. If you looked at the continuation curves, that is the curve that I think is going to be the most favorable in terms of impact outcomes. But then once you've specified this method mix split and its transition from 2025 to 2030, it will execute those calculations per method per year. And that is further breakdown of the type of planning you then have to do around a prep program, just providing the denominators, but you can go further into costing with the Prepper tool and look at the cost of training, demand creation, program management, and other elements. But these are the denominators for the commodities of the different products and the service that you need for prep. So shall I stop there at this point for prep and give our colleagues a bit more time to play around with the tool?
This is great. Thanks. Thanks, Carol. Colleagues, if you have any clarifying question, I see the chat has been busy there. I see John has been responding to a number of clarifying questions there. If you are stuck, just indicate. It would be good for you to leave the workshop knowing where to go and what to do and how to read and interpret the outputs. And also feel free to practice this outside the workshop. We may not have all the time now to spend more time on the exercise. What we would like to do now is we're going to wrap up this this section so that we can get into another two. So feel free to practice. Feel free to go through this exercise following the instructions that Carol provided, or the explanations that he provided. If you get stuck or you've got any questions when you're on your own, feel free to write to us, and we can always direct you to where you can find the help and explanations that you can be good at doing this as part of your either work or planning, or as you plan these global fund applications. You would need to estimate your need, be able to provide justifications how you got to that estimate, be able to cost it, and providing the methods that you use to do so in your applications. I think as a wrap up to this, I would like to give to my colleague Heather Murray. I don't know, Heather Murray, if you wanna, I know you've been typing the response to that question around tile and prep coverage scale up. Maybe you may want to just provide a quick response to that as you come in also to do the Menti as part of wrapping up this exercise. So over to you, Heather Murray.
Hi, Lucius. Apology though to everybody. I was having some issues with my microphone before. So Midnight had a great question, which is about oral prep coverage in the region being very low, and whether there is guidance to countries in the region to significantly scale up. And of course, I don't think it's any surprise to anybody on this call that PrEP coverage in the region is much lower than the targets for 2025 or the new upcoming targets for 2030. And certainly it's much lower than the PrEP need. And so part of this is linked within this region particularly to having some very populous countries in the region which have very small or practically no PrEP programs to speak of. And more broadly, there has been a really general slow and low impact rollout across the region of oral PrEP. This has been the case for many years. So while it might be tempting to say that perhaps the USG funding stoppages are partly to blame for this, and there has been some impact, coverage has been low and not on a very exponential trajectory before that. So we are strongly encouraging countries to scale up PrEP, to scale up prevention. This is reinforced and will be reinforced through the upcoming global AIDS strategy and also the accompanying targets for this. We're working with a lot of partners on this, including the Global Fund, who are also encouraging high prevention and PrEP coverage. We know that there is work beginning to introduce lenacapavir, for example, as a prevention mix into the prevention and PrEP mix, but that doesn't mean that we don't forget scale up of oral PrEP, which is obviously very useful and helpful, and it is part of offering choice. So ultimately there is much more work to be done, and I think as countries are really looking at their PrEP needs, what I'm hoping is that this will also encourage a lot more discussion, frankly, within countries about how far from targets they really are. Because I think at the beginning, it really sounded like if we roll PrEP out to 1,000 people or 5,000 people, that was going to make a difference. Really, PrEP needs to be available and used by, many, many more people within most countries. So as Licia said, there is an option now for you to give us some feedback around your experiences with using this tool via a Mentimeter. So I am going to share my screen and just give me 1 second. But please if you have a phone available, this can be a great option. Or you can go to www.menti.com and the code for this Mentimeter is 59159201, or as I mentioned, you can just scan the QR code. Feel free to give us a thumbs up to know that you're here and that you're participating. So the first question that we have, and it's a very short Mentimeter, is around what surprised you about the inputs into the prevention needs estimates, tools, and spectrum. So what was interesting or unexpected? Was there something that was particularly good or particularly difficult? I can see that we've got 9 responses so far, and we're really keen to hear what was interesting for you using this tool. No surprises. No surprises is great. It was concise, seemed updated already. Size estimate input for AGYW. I'll give it just a few more seconds. New indicator. What's very interesting about the feedback in this region compared to the other regions that we have done is so far the no surprises and the nothing. It seems like everybody here is very was already either expecting it to work well or already had some experience with this tool. Okay, so we will just go on to the next slide. Oh, condoms. And apparently more than one person has been surprised about the condoms. So the next question is very similar, and it's really, so instead of the inputs, what surprised you about the results of using this tool? And we know that you've only had a very limited time to play around with the tool and to see what those outputs are. But was there anything that surprised you about those results? Apparently nothing. So we've got no responses yet. The allocation of the targets. So just a few more seconds for people to respond. Okay, well, Lucius, I may hand back to you.
Thanks so much, Heather Marie. Yeah, this is very useful reaction. I think maybe it could be a sign that maybe a number of colleagues did not get enough time. I see some of the responses are only starting to come out now. Maybe people didn't really have enough time to then have a look at the results and be able to interpret them. Feel free to reach out when you get to that stage. I think to reach out if you've got any questions or if you need any further clarifications on how to read the outputs. I think that part of the exercise, it requires spending more time understanding your epidemic, understanding your programs, so that you can make some meaningful interpretation of the outputs from these tools. Would like to get to the next two, as we highlighted earlier on, that after the detailed overview and functionality and the assumptions of these tools that Carol provided, we want to go into detail into specific needs estimates. We've just covered now one on PrEP, and we had a detailed walkthrough of the standalone tool, PrEP-IT as well, in addition to seeing how PrEP need is done in Spectrum. The next presentation is going to cover condom need estimates, and we have also an overview of condom needs estimate from CNET, which our colleague Clemens is going to cover on. And then we have a condom needs estimate from CNET as it is done in Spectrum, which Avene Health is going to cover. So we'll start with how it's done in Spectrum, and then we have Clemens cover the standalone to the CNET 2. After that, we'll look at the key population size estimates from our colleague Eileen. So over to you, Avene Health. I'm not sure if it is John now or it's still Carol who's going to cover the condom need part. Over.
I'm happy to cover it. So
Perfect.
Is my screen sharing and showing?
Yes,
Yes.
it is.
Okay, great. Yeah, I hope there's a bit of time still somewhere to go through some of the comments on PrEP, and particularly a comment around AGYW coverage, which may be confusing to see it there for this region, although it is a group that is receiving PrEP in at least some of the countries, but it's more relevant perhaps for other regions of the world. So as with PrEP, there is a few high-level comments that I can make. I don't want to go into details about condom programs in the region. Just as with PrEP, want to mention that there are very significant gaps remaining in achieving either 2025 or new targets in 2030 due to many factors that include funding, perhaps not as relevant in this region as in other regions, but also structural and other barriers. So this is just a simple graph showing the distribution of condoms, or the 40 million condoms, how it was distributed in 2024 between about 35 countries here. At 400 million, that's significantly below, very significantly below the targets that are set. The condom use picture, as from self-reported data, is a bit complex, with several countries showing mature programs, but many others showing declining trends in self-reported condom use that we obtained from DHS anyway, and decrease in also in very important populations. So I think it's quite a challenge to analyze this in the context of a combination prevention program for certain high-risk populations. In the global strategy, there is this target of 90% of people in need of prevention options receiving it, with 95% of the estimated need for condoms being available. And so that estimate is what we'll be looking at. What is the estimated need for condoms? And another target that 80% of people use a condom at last sex with a non-regular partner. So we'll look at that briefly. In terms of what targets are set, I mean, if once we translate these targets in 2030 to an estimated number of condoms for 2030, so that is estimated to be around 25 billion for this region. So this includes condom use in family planning settings. So it's higher than the 20 billion, that was mentioned early on, pertaining to global condom needs targets. But the point is that it is a very, very high target relative to where we are now. And almost all countries in this region need significant scale up in most of the populations in need of the protection of condoms to reach targets. So again, in the tool, you can select your country in this region and other countries in the world too. So here is Nepal selected. These population sizes are selected or are specific to the CNA tool. And this tool, like the PrEP tool, was meant to streamline aspects of the PrEP tool. This tool also has a more detailed counterpart, the CNA tool. So here we use its population breakdown. Default data, again, comes from a database. We have baseline estimates for baseline coverage levels, and we can go back into where those defaults come from. And then we have the target levels that I mentioned, and some additional information around the number of sex acts per person in this specific population group on the left-hand side, and also wastage. That is another cost to the program that we account for. And then similar to the PrEP calculation, there is a calculation in 2025 and in 2030 and a linear interpolation in between that the workbook does. So that's just the sort of the high level explanation. By now, you can see the pattern of these tools. they they have a very specific population structure around the targets that are set. These inputs that you provide, the denominators that you produce here, are meant to provide inputs to target setting for these populations. We have an estimate of their sizes, we have an estimate of baseline coverage, and we have a calculation of what the target ought to be consistent with global targets. But that is something that each country and each program will have to evaluate more carefully for itself. What is feasible, what is affordable, what how well it's going to reach impact targets. There are many considerations that you have to work through when you finalize these targets. There's also recent, we have estimates for the number of sex acts that come from DHS and other sources that John can elaborate on. And wastage, which is also a difficult thing to estimate. I think we're going to hear more about that in the CNET presentation that will follow. But this is the pattern of our defaults aimed at illustrating what the need will be if the targets are met. That is the main purpose of this default illustration. You can then customize it. Key considerations, we all again have estimates of population sizes that have uncertainty, like for female sex workers and MSM. We also have uncertainty about condom usage within the groups and of wastage. All of those would need review. The global targets, as I stated here, are very ambitious, billions of condoms in the region. Is it feasible to reach the global target for your specific country? That is a discussion. But what we can say is that from our work in efficiency and impact and other analysis, condom programs are highly cost effective, and they are often cost savings in most of the settings. And well, not only will any deterioration of condom availability have serious consequences for new infections, I mean, they would really make it difficult to reach the impact targets by 2030. And without further scale up even, that would be very difficult to reach. So I'll stop there as a high-level overview, I think. Lysias, do we now have a presentation on CNET details?
Yes, our colleague Clemens is going to cover on that presentation. So thanks so much, Carol, for that overview of
And then we can go back to the workbook, right? Or
yes, yeah. We'll have Clemens present, and then we'll come back to the workbook and have a quick look before we can have a Q&A. Yeah, over to you, Clemens.
Thank you so much, Lysias, and thanks to Carl for showing an overview of the calculations in Spectrum, which are very closely aligned to CNET. So CNET is actually using in principle the same approach for estimating the condom need, but in its scope it goes a little bit beyond the spectrum needs estimation into a full programming tool. So I hope you can see my slides now, and I'm just putting it in presentation mode.
Yeah. Good.
So the condom needs estimation tool was actually developed as a quantification and programming tool by 2017, and has since been updated and is available through the Global HIV Prevention Coalition webpage. You have the link here represented. My colleagues can also put the link in the chat while I'm speaking. So why does it matter? As Carl has shown already, even in this region where there's a long history of condom programming, particular, of course, and starting in the early epidemic in sex work settings, we still have gaps, even among the most affected populations, where we have the highest rates of use in some countries, like sex workers, so exceeding 95% use in some countries. We still have quite substantial gaps in some other settings. If you look at some of the countries represented here in the light pink color scheme. So there is great potential to optimize. There's also inequity in condom access and use. There's still some, lower levels of use among populations with lower income levels. CNET version 6.2, which is the one that is available for download, is a prevention needs estimation tool, but also a data and analysis tool that can be used to really understand the whole condom program, triangulate, different use data, which is from surveys and distribution data. It's a people-centered program design tool, a costing tool, and it's really sort of a catalytic process that helps the different players in this space to gain consensus. And maybe one word here on how this is relevant in the Asia Pacific region. Of course, you have quite a lot of countries where a large proportion of the condom need is covered by the private sector, by the market. I mean, if I trust online sources, for example, in China, there's a market of 5 billion condoms in terms of sales. So really large markets here. And perhaps in this sense, the use of this tool might be different from, other regions that are primarily, depending on government procurement or Global Fund procurement or UNFPA procurement of condoms. I guess the main benefit in this region here of a tool like CNET is to understand the total need and then see what is the market covering and where against this total need we actually have gaps for programmatic intervention. And that may be, for example, sex work settings where we have the greatest HIV benefits and some, more marginalized women in sex work being left behind. Or it could be adolescents beyond HIV, right? And this is perhaps also a difference to the PrEP-IT tool, that the condom needs estimation tool is, of course, a tool that, is relevant for HIV prevention, STI prevention, and also pregnancy prevention. Particularly, we know, of course, long-acting contraception is also, dominating contraceptive method mix in many countries. But we know, for example, for adolescents, globally, condoms are still the number one contraceptive option. So the CNET is really a tool that puts the condom need in this holistic, multi-purpose perspective. So the methodology, and I will not repeat it, follows basically a step-by-step approach that Carl has already shown. It goes from the priority populations. It also actually, and that's maybe an additional step, factors in availability and baseline information, both from distribution data, but also triangulating that with data from surveys. And then it also goes a little bit more into condom method mix of male and female condoms, specialty condoms, and lubricant need as well. So here you have on this slide, you have actually a comparison of the spectrum needs estimation, which is, including all the basic features of CNET for the needs estimation, and then the CNET tool, which has a broader programming perspective as well. Now, data entry in the CNET is very similar to what you have seen from Carl. It starts with demographic data. It then has results in terms of condom needs estimates presented in those different ways, with some additions here, and in terms of disaggregations, as mentioned, lubricants, for example. And CNET, of course, is also a tool that can be used then for your country planning, national condom program planning, and GC8 proposal development. There is a detailed CNET user guide, again, on the Global Prevention Coalition webpage, that describes that people's lens in terms of programming for different populations, as you also see them represented in spectrum, of course, whether it's a key population or the other populations. with the use, of course, for condoms extending beyond HIV, so also contraceptive, condom use for contraception. And it describes this process from, just the forecasting, which we know is often, you use last year's distribution, maybe you add 2% for a population growth or an annual change, which is useful for forecasting in a stable system. But if you want to turn around the system and say, okay, we want a proactive programmatic intervention to optimize use, to increase use, then the needs estimation tool like the CNET or of course also the spectrum are important, so that the need is not just determined based on current distribution and sales, but a more holistic approach. So maybe this is just in summary, the People-Centered Condom Program is, of course, an important and remains an important component of the combination prevention, actually, because levels of condoms haven't been rising dramatically and in some countries even declining. We often overlook that, of course, still a very significant levels of protection are provided through condoms. Imagine if, in the settings with sex workers, condom use drops from 90 to 80%. That actually doubles the unprotected acts, because, they move from 10 to 20%. And of course, even if you increase viral suppression at the same time, that can, of course, mitigate this, but it will still have an effect, of course, if you have such increases in the number of unprotected eggs by declining condom use. So it's certainly important to keep monitoring this need and optimizing programs. I think here this is just a couple of the benefits of CNET in terms of this holistic analysis. Let me maybe mention there has been one application in this region in Thailand that has looked at CNET and using CNET for planning. I don't know whether there's anybody here involved in that. I'm presenting this on behalf of my colleague Henk, who was also leading this analysis and could be a resource for other countries in sharing this experience as well. And again, it's important to consider in the Asia Pacific context, of course, many countries with strong private sector markets, some still with some elements of social enterprise and social marketing as well, but probably less so. And using this for sort of a holistic picture to see where can actually public health intervention complement market dynamics is probably one of the key use cases in this context. So with that, back to Lysias and Carl, maybe for a more practical perspective again on how to do this and how to approach this. Thanks.
Thank you so much, Clemens, for that overview. Yes, we'll give back to Carol to just show us in Spectrum how this works. We won't spend a lot of time on that. So we have another presentation on key population size estimates. So Carol will just show us how and where to find this in the Spectrum suite of tools, and we can work. We can just also do a quick show on the Excel version of the file that we shared earlier on. Yeah, over.
Okay. Hi, Lysias. I'm just gonna share my screen here. Okay. I hope that's showing. That is the
Yes. Yeah.
Spectrum interface. So I'll jump back to the Excel version in the interest of those who haven't got Spectrum open and running yet. But once you have your national aim file working, you can load it. These estimates are drawn from a database, many of the things. So I think even before you've finalized your aim file, you can already get a sense of how this tool works. But it's tied to your aim file, and all the edits that you make, let's say, for example, now talking about the condom component of the tool, all of those edits are saved with your file. So next year, when you do your estimates again and you want to study the progress in, let's say, a condom program or a prep program, you can, all of your inputs will be saved and associated with your AIM file. So over time, even though there's a bit of investment now to learn the new components and populate the editors, that will ease over time, I think, and become a valuable planning tool in the estimation cycles to come. Just jumping back to the Excel, I think I should share my whole screen to make it easy. Yeah, so we've shared with you a link to the workbooks for the condom calculations and the prep and VMMC, not important in your setting. But as we've discussed, we have these specific populations that we estimate sizes for. We can go again quickly to the presentation in the beginning that summarized sources of population size estimates. So for the condom program, which a component, which is the first column, you can see that we use again a variety of sources, key population sizes from the Atlas work. We have the World Population Prospects estimating age categories, condom use patterns, or condom usage we estimate from DHS, and so on. Back to the Excel workbook. All of you can see the defaults are here again listed in this extra sheet and pulled in from there. So if you disturb a linkage there, you won't be able to reinstate it unless you copy back the formula or reopen the workbook. And in Spectrum, you can always go back and reload the defaults. A fairly simple tool. We have the population sizes, as I mentioned, baseline coverage levels, which you can study and compare to various informations, surveys and other sources of information. We have our best attempt at a default estimate here. The targets are more clearly stated from the UNAIDS targets work for 2030. Important input will be the number of sex acts per person in a population group per year. These are, fairly average estimates, and you can review that if you have any information. I think that there aren't often not much information on that. Wasted is a specific condom program characteristic that you can estimate through methods, but ultimately a very straightforward calculation. And we don't have the mix of condom types like male or female condoms. It's just the overall condom need per population group that is listed here as an entry point into a more detailed analysis that you can do with CNET for a complete program, planning of the condom program. The bit of work that you enter into this tool, ideally through Spectrum, not through the Excel workbook, since it follows a near identical structure to the CNET tool up to the point of the estimation of overall condom need, you can copy over most of this inputs that you develop. So if you've edited population sizes, or if you've studied and developed targets, those you can copy over, all of these elements. So it's once it's into CNET, you can do much more detailed analysis. But here in Spectrum, you can already study very important elements of your condom program. You can look at total condom use in 2025 and compare that to whatever information you have on the condoms that you've distributed. It will not be easy to get that to match numbers exactly, but at least you can get an idea if you are in the right ballpark with respect to these estimates produced by this tool, and you can then likely start to adjust some of the key inputs here, of which population sizes are typically go with quite an uncertainty associated with them, but also around these estimates of wastage I think those can look quite different in your specific country programs. But ultimately, you have a way of comparing it to baseline information and then ultimately study the target, of which most countries are significantly behind at the moment. I hope that was useful, and yeah, I'll study the chat for questions. I think there's
Thanks. Thanks so much, Carol. Yeah, I hope those two walkthroughs, one on PrEP need estimation and this one now on condoms, together with the accompanying presentations, helpful for colleagues here to be able to navigate these tools in Spectrum. And we are hoping that after the next presentation, we can have a discussion and hear colleagues' feedback, their thinking process, how this could help them in the GC8 application processes. I'll hand over to my colleague Eileen from the Data for Impact to provide us with a quick presentation on the other part of this suite of tools. When you see that screen from Carol, there's a section on key populations there. So Eileen is going to show us or present about that part of the suite of tools. Eileen, are you? Yes, I see your message in the chat.
There.
Uh,
Hi.
Yes, over to you, Eileen. Thanks.
Yes. Thank you very much, Lysias. And good afternoon, evening for most of you. I have a very short presentation. Let me share it at once. It's about the source of the key population estimates that are loaded in the Spectrum tool that Carol just showed. Can I confirm if this is visible?
Can you put in presentation?
Yeah. 1 second, it's coming. There, is it good now?
Yeah, yeah, perfect.
Okay.
Thank you.
Yeah. So these estimates here, these estimates were updated based on country reported data in the end of 2025, quite recently. Here you see again what Carol just showed. So it's for the key populations, 4 of them: female sex workers, MSM, transgender women, and people who use injection drugs. What is behind these consensus estimates that are used for the calculations of condom need, key population counseling, and PrEP for these 4 key populations? The basic source is what national country population size estimates reported by your country to the Global AIDS Monitoring, and UNAIDS compiles that. However, there are additional valid and representative national population size estimates that have not been reported through GAM. In such cases, we have taken them along in what we call a consensus estimate. For example, if your country uses the AIDS epidemic model for the Spectrum HIV estimates, there may be key population sizes estimates inputted in there that are not necessarily in GAM. And if that was the case, we have looked at the key population size estimate used in the AEM model, or if it were EPP concentrated, and if that was up to date and valid, to supplement the GAM data. And that was felt a most valid source because it forces the population size estimates to be consistent with the burden of HIV in each subpopulation, as well as with the national overall burden, matching the national program data. There are a few countries that have not reported a national population size estimate to a GAM, nor in the Spectrum AEM or EPP model. Or they may have some key populations, but not all of them. And in such cases, we have used a regional median population size estimate as a percentage of adults of the above sources from neighboring countries, so in the Asia-Pacific region. Of note, these same population size estimates for all countries, all key populations, were the basis of a UNAIDS update of key population infection estimates published in the World AIDS Day Report 2025 last December, with trends in new HIV infections from 2010 to 2024 for each key population globally. And the same population size estimates are also being used by the Global Fund now for the Grant Cycle 8 grant allocations. Here are the regional medians that have been used for countries where there was no national estimate available. So you would look at the Asia Pacific, the top row here. For example, for sex workers, if there was no national estimates, it was assumed that these were 0.28% of all adult men plus women 15 to 49 years as an imputation. This table with the regional medians as a benchmark, if there's no national estimate, you can also find it in the Spectrum user guide as a table. That's been posted online and shared with you in the context of the Spectrum estimation. When was it? I think the 20th of January. And lastly, just for further information, really, here at this link, you can find the infection estimates that use the same population size estimates published by UNAIDS for the global total and regionally. That's just for reference. Thank you.
Thanks. Thanks, Eileen. Very helpful. Now we have, I think for that which is relevant for the region, we've got the different pieces covered now. This aspect that Eileen presented on key population, it links back to the question that Pradeep from India asked earlier on, where are we getting the size estimates for key populations? I think this clarifies, and this question also has been coming throughout different workshops. Where are we getting these values for the size estimates to impute into those tools where the default values where you can make edits are highlighted? So this kind of ties everything, covering an overview of the different tools that are relevant for Asia Pacific in Spectrum, and also covering in detail the two standalone tools for PrEP estimate and also for condoms, the CNET and the PrEP-IT. And then now the size estimates is part of that exercise. Are there any questions? I don't see any questions that have been coming in the Q&A. There's been a lot of engagements, a lot of exchange in the earlier presentations. Any questions on condoms, on the CNET 2, on key population size estimates? Any questions for these three presentations? And also any reflections around this and Global Fund processes like the GC8 for those countries where it's going to be relevant. Feel free to raise your hand if you want to share any reflection or you want to ask any question, and we'll unmute you to speak. There was one question here on sexual acts. I think it has been responded to. Let me check. Just to be sure, the annual number of sex acts requiring protection refers to person per year for that group. Yeah, I think that has been responded to. A question from China, I think that's for you, Eileen. What is the denominator of the key populations?
Sure, thank you. The key population size estimates for analytical purposes and for imputing missing values are always adults 15 to 49 years. And for simplicity, we take men plus women. So in the table I showed, the 0.28% female sex workers is out of men plus women. If it were just the women, it would be roughly a double percentage. And that is just for the purpose of standardization, because of course, the absolute number of persons in a risk group will vary with the country size, but the percentage is expected to be more similar across small and larger countries.
Thanks, thanks, Ellen, for that clarification. I'm not seeing any additional questions here, so I will have to hand over to my colleague to do another Menti. So yeah, over to you, my colleague Heather Murray, who did the earlier Menti on the first part. Now we can do another quick one. Whilst we do that, feel free to just come in if you've got any questions, any clarifying questions. It's good for you to leave this workshop really knowing that you've learned something and you're comfortable navigating these tools in Spectrum. Over to you, Heather Murray. Thanks.
Hi, everyone, and welcome back to our Menti. Wait, let me just check that you can see my screen properly. Okay, it should be good now. Okay, so if you're already logged into the Menti, you don't need to do anything. We will just move across. But if you haven't had the chance, please do scan the QR code or go to www.menti.com and enter in the code. So it's two final questions with us today. And the first question is a very easy one, I hope, which is how confident are you in using the Spectrum Prevention Needs Estimates tool? And so this is a scale from 1, which is I don't feel confident at all, to 5, I feel very confident in using these. And I will just give you a little bit longer to respond. We've had 5 people respond so far. And so, yeah, so we would love to hear from you. So if you can, log in, go to menti.com or scan the QR code. So we have quite a mix of answers, but they do seem to be clustering on the fairly confident side so far. And I'll just allow another few seconds for those, for anybody who wants to respond. Okay, and so the final question that we have today is, how do you see your country using these tools or the results of these tools in 2026? Do you see a use for them in your country? And one person is at least giving it a thumbs up, which I will take to mean, yes, we do see a use. So just a couple of words to give us some feedback on what these tools might be used for, or what the results might be used for. For monitoring prevention progress against the targets, that is one of the things that we hope. Any other responses? So noting the time, I'll just give another 15 or so seconds for people to respond. We have another response, which is during the NSP development process. And target setting, of course, this is going to be very timely for many countries who are going into GC8 window, GC8 window 1. So for setting target for Global Fund proposal and NSP. Okay, just 5 seconds left. If there is anybody who would like to make any other comments about how you see your countries using these tools or the results, and we have the development of the Financial Sustainable Plan, absolutely something that I think is on a lot of countries' minds, and also Global Fund. I will leave this open for just a little bit longer, but I will pass back to Lysias. Thank you, everyone.
Thank you so much, Heather Marie. Great to hear those reflections from colleagues on how they see using the learnings from this exercise throughout 2026. Yes, it has been also our desire that we link this to the Global Fund, as we know it's one of the key process that will be coming up to countries soon. So we hope that this exercise will help you to provide the method of quantifying your ask in the proposals in a scientific manner and be able to present that to Global Fund through your proposals. That's all. We have started with an overview from Mary from Data for Impact, who provided us with a link between prevention needs estimates and the overall estimates process, how these are very closely linked together. Then we had a presentation from Clemens linking this to the Prevention Access Framework 2030, after which we had another overall detailed presentation from Carol on the suite of these tools in Spectrum, looking at the key populations, the condoms, PrEP, and then for VMMC, where the VMMC aspect applies. And then we went into detail into the specific tools, of which we covered 2 main tools here: CNET for condoms, and then PrEP-It for PrEP needs. And we also covered how these are covered in Spectrum suite of tools. And then we had an exercise, which I hope it was very helpful for you, a walkthrough of these tools in Spectrum, the condom piece and the PrEP piece. Hope that this has been very, very useful for you. Not enough time yet to practice, but you have these resources we've been recording. We're going to share the slides. We're going to share the recording. You can go through that again and you can practice. We will also share again these Excel files as well for those who might have missed them, and a sample Spectrum file so that you can practice on your own and be confident on the use of these tools. I want to hand over to my colleague Clemens to close this session. Over to you, Clemens.
Thanks so much, Lysias. And the question probably now at this stage, and it's been a long webinar, is where from here? And maybe let me just say that we received quite strong demand from the global group of national AIDS councils that is organized around the Multi-Sector HIV Leadership Forum to actually lead from these needs estimates into supporting strengthened country prevention plans. So I presented at the beginning of this call the global targets and the global HIV prevention access framework. And the idea is to avail additional tools, for example, templates for national prevention planning along those lines. That's why I'm pulling up again here this summary graphic that shows on the left side what could be at the country level, and this is just illustrative. The needs estimates for the different prevention options, and then how they could actually be used for planning and segmentation. And in a way, this is a new era of prevention. And this is exactly the ask that we've had from the NACS in this new era of limited resources. We don't have that growth in HIV resources anymore that we saw maybe a decade ago. We have stagnating, and in some cases where we rely on international resources, declining resources. We have new options, new prevention options. So time to really have a tool and an approach for overall planning of an optimized prevention mix and the shared responsibility for financing it. So the idea would be from here, use those prevention needs estimates, as you all said in this last slide, not just for global fund planning, but really setting out a national prevention agenda that can then be used to inform different funders' contribution. And in a way, in doing this systematically, HIV could again be a pathfinder for public health, because for other diseases we may have a single vaccine, or we may be rolling out vaccines. For HIV we don't have that, and for few other conditions actually we have such strong data tools to understand the epidemiology, project forward where our next new infections will be happening, and then align those prevention investments so precisely to the need, both in terms of products and populations. So with that, I think we'll leave you with this material, and I'm happy to re-engage again in launching this framework, discussing this framework, and understand your perspectives on how this can be useful at the country level. So thanks so much again, and we look forward to staying in touch on HIV prevention and specifically those needs estimates. Thanks so much.